So we're going to move into an interesting part of the afternoon, in which I'll ask Roundtable members to identify one or two key lessons from today's workshop. And we'll try to give everybody an opportunity to speak. I won't go through alphabetically. I'm assuming that everybody is one way or another going to raise their hand. You know, just as prior to that, we're entering the holiday season very shortly. We have Passover and Easter on the same weekend, and I think Passover starts Friday night, and Easter Sunday is Sunday. and so at the Passover Seder, we usually ask a question as we begin: why is this night different than any other night? You may know where I'm going now. And so there are some specific answers to that. You have leavened bread rather than, unleavened bread rather than leavened bread. You recline, whatever. I have a fifth answer, and that is everybody leaves their iPhones this night, which is different than every other night, outside before you come for dinner. So it adds a little bit to the evening. Nobody has an iPhone. Okay, so let's open up to the questions, and we'll go from the round table to what did we learn this evening? What did we learn today? Rima.
Thank you. I was very taken.
Yes, please use the microphone.
Yeah, we're going to have to use the microphone. So everybody might as well line up. Of course. I was very taken by the last panel. I'm sorry, I'm Rima Rudd, member of the Roundtable. I was very taken by the last panel discussion for several reasons. But the major one is that and Winston brought this up, but so did Kim, brought up the notion of community. And suddenly, I felt that there was a shift in focus from the individual getting information, for example, about my asthma and how it's improved or gotten worse over time, to perhaps the notion of what's going on with asthma in our community. Because once you are talking about community, the potential for change and action is great, is grand. Needing to take action by looking at the housing stock in the community, by stopping the idling buses in the community, changing the traffic in the community to deal with asthma in our community. So I really love the notion and that possibility of a shift going from that right to data, only focused on individual data, to focusing on community data. And there's a potential for public health and magnificent change in that. So that was a major factor for me. And I'll just highlight one other notion, is that I'm very buoyed by the fact that there is renewed attention to formative research rigor, which has long been well established. And it's almost as though people are discovering it wonderfully for the first time. The idea of the participatory voice, of knowing your audience before you take any action whatsoever, of getting the voice of the people who make up the intended audience in the action itself, and making sure that you rigorously pilot and repilot and change as a result. We do not allow drugs on the market without that rigor, yet we allow messages and information on the market without that rigor. And so information that is not accessible cannot be accessed by anyone. So I really was very happy about that point as well.
Thank you. Stacy?
Thanks, Bernie. I think what was amazingly important, and it's nothing new, but the importance of a truly customized approach to any of this work for it to be meaningful and valuable, and that a group of pregnant women is different from a group of Native American individuals, but the value that each individual gleans from comparing their data to that of their community, and how meaningful that can be in, getting toward an end. And then just secondly, again, nothing new, but the importance of the end user being involved in the creation of all of these in the medical community, both the patient, member, community citizen, as well as the care providers, because without that, it's what has created so much of the mess that is the EHR world, what we all live in now.
Thank you.
I'm sorry, I'm Stacy Rosen from North Shore LIJ.
Chris Desi,
Chris.
Roundtable member, Bristol Myers Squibb. Apps aren't a panacea. It's more than the apps. Apps are tools that may or may not be useful dependent upon patient needs. That's what I'm starting to get here. Though the prevalence and penetration of technology in 20 years, I think, is going to be very different, which really sets up two pillars in my mind. One is for the next decade, we can try to find those apps that are successful and deal with the kids today. Also preparing the infrastructure for 20 years from now that we'll all have something, and probably prices will come down so that just about everybody can have whatever they have whatever my kids have today. Okay, that's one. Another important issue, as far as I'm concerned, is the linkage of technologies with providers. I started off this discussion this morning about the concept of interoperability, not just with the apps themselves, but frankly interoperability with providers. Okay, health literacy. I come from the transplant realm way back, and you know, where frankly it was all about patient education and health literacy. You know, you used crayons, you used storyboards, you used whatever you did to be able to. We actually had illiterate patients dipping their urine for pH, all right, which I was pretty proud of back then. At any rate, I'm still getting the sense that health literacy and patient education is still considered a luxury to be prioritized out. There's always something, I have more important things to do. I think that has to change, and of course, well, Chris, how are you going to change it? I think accountability for health literacy via performance measure development with the accompanying reimbursement. Okay, I'm a measure guy, I'm a quality guy, so I think that patient engagement measures need to be developed, and responsibility for the literacy of your patients via return demonstration. Not, you know, are you checking off the box, are you delivering these tools, are you delivering all that, but, you know, do they know what you're talking about? And I'll just finish with, and I know a lot of this stuff because I've been with patients in the hospital who sign a consent, and then everybody goes, and I sit back with them, I said, now what did you just sign? I don't know. We really have to get away from that. Okay, thank you. Thank you for the latitude.
Thank you. Robert?
During Dr. Chris' talk, he was talking about the user evaluation of patient portals foster surprising findings. And for example, he told us that the senior use of the portal was much higher than expected, and the use by young adults was actually lower than expected. So I drew the conclusion that socioeconomic characteristics may not predict patient engagement or sustain use along preconceived lines. This raises a question for us if the conceptual framework and evaluation metrics most assessments of portals use include health literacy. And it also raises the issue of the use of health literacy as a conceptual framework, and its inclusion as part of the evaluation instrument might help predict better patient engagement, sustain use, as well as other desirable outcomes. Let me put it another way. Similarly, it strikes me that the Roundtable could be very helpful in demonstrating how the addition of health literacy is useful conceptually in app and website development, and it contributes to better understanding of intended users. It strikes me it would be useful for the Roundtable to potentially demonstrate how the addition of health literacy as a measure is a useful component within the evaluation of patient portals, health apps, and health literacy websites.
Thank you. Terry?
Hi, Terry Parnell, Health Literacy Partners. I also wanted to say this last panel was fabulous. It was exciting and stimulating, and congrats to the great projects that were being done. In preparation of coming today and talking to colleagues, when I would mention the topic, it always went to access, access, access. That's all that was, spoken about. And as we all know, I think, access is just one of the issues. It's not the quick fix. I have a 6 and a 4-year-old grandchildren that can easily access movies and download pirated things that they shouldn't be. I don't know that, as they get older, if they're going to use technology to help change behavior and to maintain wellness. I think the key points are really that, trust and face-to-face communication and listening and caring and building relationships and community engagement, are all critical to both, of course, health literacy and the digital health technology success. And I think that was so well demonstrated by the last panel. So I think we're talking about very similar issues, and we need to bring the patient or the consumer along with the professional, along with the community together, along the journey so that we have a product that is useful to all and meaningful. If it's not meaningful to all, no, they all won't use it. Thank you.
Lori?
Hi, Laurie Myers from Merck. So I wanted to reiterate the importance of the system factors in facilitating the adoption of health technology. So we talked ad nauseum about many provider barriers to the adoption of health technology. And so I think there's a few thoughts there, which is, one is the importance of the team approach and how do we potentially take advantage of that in helping to reduce and address some of the disparities. And if opposed, just if some of the evolving payment models may help with that. Making these types of information that they get actionable and part of the workflow. And so there probably have to be filters put in place, right, to help to say for everything coming in, are there things that are actionable that can be, that can be helpful in patient care. And then needing the evidence of improved quality and patient health outcomes by doing these things. From the patient perspective, Yarima did a wonderful job talking about the importance of community-based participatory research, and I think we heard that in your case study and many others. I still think there's probably lessons from gaming in terms of stickiness and other things and simplicity that are probably worthy of additional study. And finally, aligning, and again, to come back to the last panel, aligning incentives to things that are important to the people rather than having what's important to us, what's important to them, and listening. So that's it.
Thank you.
Good afternoon. Lori Hall from Eli Lilly and Company. As we started out the day, one of the first thoughts I wrote down was that, borrowing from Dr. Pasharlo, about the educational privilege that so many of us have, and that oftentimes the current digital strategy, that space engages people who are already engaged, who are already activated, who are already self-confident, confident in their care. And so we're just going back to those same patients who are already activated. But what happens for those who are so underserved and don't understand and aren't engaged and aren't activated? So as the day went on, my spirit started to change and lift and started to think about, through the work of Dr. Kim and others on the panel today, I realized how important it is to remember that technology is a tool for something much bigger. And when used in partnership with true engagement, where we first seek to understand and listen before we make assumptions and start to design or start to act. So ultimately, this is a statement about where technology is so important, but it never will replace empathy.
Thank you. Ernestine.
Ernestine Willis at the Medical College of Wisconsin. This has been a lift in dialogue. I think because the relevancy is what's important. I am a community-focused pediatrician, but making sure we walk away understanding that whatever we design when it comes to health literacy, it must be relevant to the specific population. It's true that Dr. Kim's research basically showed it's possible. The other thing that I think, besides building the trust, we have stereotypes of communities, especially the hard to reach and disenfranchised communities. For us as professionals to move beyond that and to have a broader lens that we begin to see them from a new perspective as well as looking for opportunities to think outside of our box. We tend to want to say we must make the community fit into our randomized controlled trial box. And I would say this is an opportunity for us to come up with new methods, new analyses and methodologies that we can begin to get a better picture of what it's like. The other piece is that we do not have all the answers. Many of the solutions and the creativity of new opportunities is really in the community. And I think we need to be open for that, and I'm hoping we'll explore some of that as we go through the next several years.
Thank you. Terry?
Terry Davis, LSU Medical Center, Shreveport. Well, first of all, it was really cool meeting the guy that designed the mouse. I've already emailed that to people, and they've written back, "Oh, that is so hot." So anyway, but the theme, it seemed to me, was that, and I learned some other things from you too, but that whatever these devices or apps or whatever are, we need to work with the people that are the users in the context, this is what I learned from you, of the story of where they live and who they are and where they want to go. And it has to be useful, user-friendly, and hopefully a little fun. And then from you, I learned and knew, but maybe we have to bridge the divide a little by teaching people how to use these things and making them more user-friendly.
I know Terry for 20 years. She's never lost her sense of humor.
Hi, Maren Allen, NIH. Something magical happened today, and it was Dr. Kim's fault. And I think that what she did for us is exactly what Dean started out with, which is she created a story arc that I would guess is the one that we will find most memorable from this meeting today. And I think that part of the going back to the story arc concept is that's what we're trying to do for both the patient and the provider, which is to create an arc of where are the stops along the way that will end up with a healthy human being with long life and improved health. And for Winston, I have a quick response to you, and it's from a couple of conversations recently. I think we have to look at resilience as well as disparity in order to tease out the aggregation that you're concerned about. For example, we made progress on celiac disease the other day, and that's actually a Caucasian disease. The good news is African Americans basically don't get it. So that's a resilience that says this is not always a bad story to be part of another group or another set of groups. And the third thing, quick things, is we need to go back to really thinking about what communication means. It doesn't just mean that everybody talks, everybody in this room reads, everyone speaks. That doesn't mean that they have a strategic understanding of the millions of years that we've built up communications. Right. And so we sort of talk about it as though we all knew what it meant. And I think it's the part that we're missing in terms of how to describe to the providers as well as to the patients. I was in a meeting with a geneticist who'd been asked to run a communications campaign. And partway through, the individual said, well, you know, this communication thing isn't so hard. I kind of get it intuitively. And I thought, yeah, and I can talk about genetics intuitively also. So I'll leave you with that thought.
Thank you. Wilma?
Wilma Alvarado Little, language access advocate. Wow, how can I follow up all the wonderful comments that have been already said? And I didn't know about the mouse part, so thank you. But anyway, Dr. Kim, thanks so much for reminding us that not everyone has access to the internet. You know, that's a whole don't get me started topic, but so thank you very much. I also want to echo Rima's comments earlier about the last panel and the CBPR. As a reminder that speaking for my language group and my ethnicity, sometimes when we go into the communities as a researcher, the community's already like, all right, here they come, they're going to tell me about me. And, you know, that's not really going to be the best approach. So, and it's also, too, that the communities aren't small. They're closely knit. And so how is the role of technology really going to help in a way that resonates with the community, even though things are well intended to be presented to the communities. So these are some of the points that I was thinking about. And there's also so many very positive things that we discussed from the beginning of the day to this very last panel, reminding us that technology does have a place, but also keeping in mind that for our other language groups, we have to ask the question, in what language do you get sick? And in what language do you access your emotions? And if it's not that patient, is that the caregiver who's going to be bearing the responsibility of care? And so what is that technology going to mean to the other individual? So I just want to say thank you. We talked a lot about, also to one last thought, we talked about, what would be the ideal practice with using technology, but then, and we also talked about research, but one thing that I feel we're not even close to, but may keep in mind is, how would this turn into an organizational policy, putting all these pieces, into appropriate places if and when they become appropriate? Thank you.
Thank you. Michael?
Michael Valère, Institute for Healthcare Advancement. And again, I thought both panels today were outstanding. I particularly enjoyed the afternoon panel because part of what we do at IHA is really about showcasing and bringing out specific practices that give context to how we use things and where information and programs and practices can be useful. And so thank you for this afternoon's panel for really showing some examples of how people are doing certain things. And so hopefully some of these things can be replicated and brought out there. I think this issue of M-health and technology in juxtaposed with health literacy is an issue of context. How do we, as some of the experts in the area of health literacy, provide our expertise to provide context for the information that is being developed? These apps are there. The trajectory is that this is going to be more and more a part of our lives, and especially as some of the non-tech savvy, as time goes by, and some of the people who aren't, tech hasn't been part of their life experience from early on, are replaced by the people who were born with this, and the digital natives, as I said before. Those folks are going to be the ones who are going to use those things intuitively, and I think there's going to be a shift here with us trying to catch up with the technology to the point where the developers are going to try to catch up with the people who are using the technology. And I'm hoping that those digital natives become more and more demanding of what they are asking for from those particular technologies. And that when I get all of this data, what does that mean to me? How does that help me? How does the number of steps I take from my Fitbit device help me in terms of what my overall health goals are? Rather than just giving me a number, give me some context. And I'm hoping that those are going to be some of the things that people are asking for. And I think it's our roles to act as influencers and as mediators in this area to advance those things and be more demanding and make sure that people not only understand those devices, those technologies, but are able to take that information and apply it, which is kind of our definition of health literacy. And also there was Reed made a very interesting comment earlier on that developers tend to build up to the immediate goal. That, in other words, in these contests, they'll build these apps, they win the contest, boom, I'm off to the next contest. Maybe what we need to do is incentivize the developers to go that step further and say, you will be rewarded on some kind of whatever the basis is, a commission basis or whatever, to the extent that these apps and these technologies start showing results. And that part of your responsibility in developing these things is to take it that next step further, to show the results, to show health improvement, to show that these are actual tools that people can understand and use. I am very concerned about the issue of access and the issue of disparities between those who can use these, get these applications and use them, and those who cannot. So I think that's another issue that we need to be very aware of.
Thank you.
Margaret Loveland from Merck. I won't repeat everything the wonderful things that have been said today, but I did want to make a comment of a point that's been made several times that struck me this morning about privacy. And I think it's really important that when we're at a health literacy roundtable, and when we think of the health literacy population, you know, these are people that are culturally diverse or elderly or educationally or economically disadvantaged. And they often have trust issues. And I think if we do not address this privacy issue so that they can feel confident, in, especially when we're talking about the apps and how their information gets transmitted, they're not going to be using them. Right now, I think the majority of these people use apps to gain information. They don't expect that their information is going to be delivered to somebody else. And I think without, you know, addressing this privacy issue, which right now I think is a big problem, they are not going to be using it. And it really is, for these people, if they have access to smartphones, which most of them do, it could help them because they do need, you know, somebody or some way to improve their health. They often have issues that, excuse me, that they don't want to be discussing openly until they've got the information or they see where they stand. The other thing that I wanted to mention just was the sense of community. And, you know, if you do start using these apps, there is a sense of community that can develop. And, you know, community is a big thing. If you look at the Blue Zones, community was one of the factors that, you know, contributed to longevity. So, you know, community's all good.
Jim?
Jim Doss with the Health Resources and Service Administration, member of the Roundtable. So I agree with a lot that has already been said. And there have been two aphorisms that have taken residence in my head, so I just want to let them go at this point. One of them is that, you'll recognize this, that is, if all you have is a hammer, then everything is a nail, right? And so the other one is that information in and of itself doesn't change behavior. And I would add, I also felt this morning like there was a corollary that technology in and of itself doesn't change behavior. And so we need the things like community, we need the listening. And I think we also, as was said earlier, that, you know, we need to connect the investment with some measure of outcome, so that we're not just fascinated by these new toys. So thanks.
Very good.
Hi, Kim Parson, member of the Roundtable, and I do consumer experience and health literacy work at Humana. So I could echo many of the wonderful things that have been said about the day and the comments and the learnings. But I'll focus on just, you know, thinking about the technology and these apps and whatnot as another channel for my health information and for my health journey, right? For me to be able to live my life with good well-being. And when I think about that, I think about the value then in these tools and in them being health literate comes then in the simplicity, right? For me, the consumer, but for the physician. So if you will, you know, once these can get to the place where they're getting rid of the noise, right? For the physician who doesn't want every piece of data, and for me who needs more than to know that I walked 10,000 steps that day, but indeed what did that 10,000 steps mean for my health that day and also for my greater health, you know, in the long term. And when it can move away from giving me just stats and again, moving beyond helping me set goals, but helping me understand what it means to my health. And then I think then that the true value then with the technology and with health literate technology comes then when it is all connected, right? So when my health team, my physician, my pharmacist, my caregiver, my family, when it can be truly connected, then it can be actionable and valuable to all of us.
Thank you. Lindsay?
Yeah, Lindsay Robinson, ADA, American Dental Association, several ADAs out there. First of all, I go back to something Katina O'Leary said during the panel Q&A. There she is. She was asking or thinking through, well, where does my stakeholder group, my perspective as nonprofit, where do I fit in to this conversation about technology, and I've been struggling with where oral health dentistry fits in to technology, but then thinking more through it, now I'm thinking that it really fits in everywhere. I would propose it fits in everywhere. When you think about diabetes, when you think about obesity, cardiac disease, pregnancy, I would hope that somewhere in the conversation, oral health would be a component of understanding the impact in all those conditions. And something Allison, one of her slides was the the social determinants. Only 10% of the factors related to health occur in accessing health care, and the 90% is out there, and that occurs so much in culture, in communities and families and the culture, and I think that's where we can really impact and improve oral health is through conversations in those areas, within communities, within families, and imbuing culture's understanding of how important it is. Because in so many cultures, especially those who come from other countries and have recently arrived here, they don't understand that it is important and that they can actually impact. They can actually. Tooth decay is not necessarily something they have to suffer from. It's so interesting to me to understand that so many people think it's just it's my fate. My mother or my father had no teeth by the time they're 25, and there's nothing I can do about it. But yes, it is almost completely preventable. So I hope we will all remember that in any time that we're thinking about developing technology, especially in a public health arena where it's something like Text for Baby, a program that is going out and really trying to improve a population's overall health, that oral health be incorporated as an important part of that.
Thanks. Sue Bakken, Columbia University. I think in thinking about this day from my perspective, I'm taking back to the notion of a learning health system, not a learning healthcare system. And that includes all this consumer-generated data. And we look at the language of the continuous learning, et cetera, report, and it talks about the importance of creating a fabric of trust for the digital infrastructure for that learning health system. And that the goal is to really engage individuals as being users of a robust data utility. So that means people need to be able to contribute data, but also to get something out of it. So one of the things I'm thinking about today is that we really, since so much of this information is consumer generated, that we really have to take on those terms of agreement in some way so people truly know what they're getting into. I'm not so concerned about people being afraid to use it, but I'm more concerned about people using it and not realizing that their data is being commodified. And when we think about what we know about consent for data reuse, we know one of the things that really differentiates between what people are willing to have used is whether or not it's for social good or for commercial purposes. And so people need to be aware of those choices. And so I'd really like to see the expertise of the Roundtable and taking work of researchers that's gone into things around drug labels and prescriptions and all these kinds of things, and really think about how we could have some newer approaches to make sure that consumers who are choosing to use these tools, more and more people at levels of low health literacy, will really know what they're getting into, because it's vital that they be part of that robust data utility for the learning health system, but it should be a very willing and trustful. And so I think part of the magic ingredient really is health literacy to increase the awareness.
Winston?
Thank you. It's been a very informative, I dare say dense day, because there are a lot of things that were covered. And in thinking about it, I had to kind of construct a taxonomy for myself. But I think it's useful because I think we need to think operationally, how does health literacy work in the taxonomy? And I think it's important that if we look at the different ways to define the population. Number one, there's patients. And patients can be categorized as individuals with an acute problem, individuals with a chronic problem, and individuals with some sort of maintenance of health or some sort of malady. And I think you have to look at each one of those aspects of being a patient differently in terms of how to construct a health literacy strategy. Secondly, there are consumers, and I think consumers have distinctly different expectations than patients. It has to do with what is user-friendly to me that day that facilitates a product or outcome that I have basically purchased. So that's another level of hierarchy, if you will. Thirdly, I would introduce member, which is kind of a vernacular that's a little bit used more in certain health systems. But I think a member connotation is different than consumer and patient. And members expect something with regards to how they interface with what they're a member of. And it could be a YMCA for all I know. And then the fourth level is a community, and how we use technology to be able to facilitate the kind of interactions and engagement between the health system and a given community. So that's kind of the taxonomy of the users. And then when we think about health literacy, it behooves the producers of health technology, as well as the individuals on the healthcare team and the spectrum of healthcare providers, wider than what we see in our clinical walls, to consider what are the operational and critical elements that we have cultivated in our understanding of health literacy. So health literacy becomes a critical strategy that's implemented at every one of these different levels of engagement between patient, consumer, members, and community. And then I think you need some work to figure out what are the critical features of health literacy as we think about how we move forward in all of these different parts of the engagement hierarchy.
Thank you.
Alicia Fernandez, UCSF, San Francisco General. This was a great day for me, a great introduction as a new member of the Roundtable, and I very much appreciated all the presentations. Two things struck me. One is how embryonic is the word I think someone used, and how completely embryonic this field is, with almost with very little known about what works and what doesn't work. The second thing that struck me is that I feel ready for the next conversation, and that one being about levers. And the reason for that is that I suspect, and perhaps I hope I'm completely wrong about this, but I think that the apps and a lot of the health informatics that we discussed today are going to be present an area that is ripe for market failure. And by market failure, I mean that there just won't be a product that's going to work for the people that I as a physician in my community, needed to work for. In the same way that as my mother started having cognitive impairment, and I said, that's okay, I'll get her a cell phone so she can always have it and call us. I thought it would be easy to get a simple cell phone, and I was prepared to pay any price for a simple cell phone, and yet I couldn't find one. And it was in that way a complete market failure, even though there must be millions of people like my mother who would need a product like that. In that way, I was listening to what the people here from government said, and about where they see their levers, and I wanted to hear the next conversation about how do we get that. I wanted to hear conversations from my colleagues like Winston Wong about what is Kaiser prepared to do or not do if in fact it is found that any of these things actually improve health. Should we be providing copays? Should we be doing these things? I also want to hear what organized medicine can do, including this roundtable in terms of clarity of standards ethics, privacy, and some of the other concerns. So very much looking forward to the next conversation.
Steve?
Yes, thanks. Steve Rush, United Health Group. Today was really exciting for me. Two things. It reinforced some of the thoughts that I've had about health literacy and technology. And second, it opened my eyes to a number of things. It's easy to make comments at the end of the day when you can say ditto to everything. But there were a couple things that really were very interesting. And if we think about health literacy as something that's accessible, accurate, understandable, and easy to use, and we apply that to what we talked about today, we have 40 to 50,000 apps out there, which are good, which are reasonable. And to what extent are we going to overload the cognitive overload of these apps? So I think that's something that we may want to think about as a organization. The accuracy, the usability. I think for me also, and it's been talked about, you need three parts to make technology or incorporate technology. The technology, the care providers, the consumers or the patient. And for me, the concept of community was brought back in. So I think that there are four, and we need to take a look at all of those. I do feel that just because we have an app out there doesn't mean that it's going to be taken, because number one, consumers may not be able to understand that burden of using that app could be a really big one. And the other piece is that it really does need to tie into how they're choosing and using healthcare, and so the providers are really necessary. This then brings in a big change in how people practice whatever type of care that they're providing. And I do know that there's been some real interesting research out there that from a sustainability standpoint, you can do an app and people will use it for a period of time because it's fun, it's something new, it's something different, but it's not necessarily sustainable without the interaction with a person. Whether it's a technical person, whether it's a healthcare professional, there's a need to have empathy, there's a need to have some level of reinforcement that they're doing something right, or if they're deviating, they need to get some redirection. But a very exciting day. Thank you.
Thank you. Katina?
Hi, I'm Katina O'Leary from Health Literacy Missouri. I just want to start. My first observation is just the energy level that we've had today with this topic and with these panels is different than the energy level I've experienced all year. So I don't know what it is about this topic or this set of panels or what happened, but it was a really fun day to be here. People are saying that over and over again, and that's exciting. And I think that bodes well for the work that we're trying to do. This level of energy begets energy, so that's a really nice thing. Clearly, everybody's really excited about the afternoon. I think a little bit of that is just post-lunch and losing ourselves because the morning was awesome too. Particularly kicking off with kind of a tour of what's out there. This is a really diverse field. We learned about these websites and these apps and these texts, and we're talking about all these different things all day long, and I'm thinking, where do you put it all? Because every one of these things has a different audience and a different place and a different kind of experience and a different user feel. So when we're talking about how communities use this or how people use this, we're talking about a bunch of different things, which is also pretty cool. It kind of helps me not feel as worried about failure as maybe you could be, because there are a lot of different options. So one whole line can fail, and you've still got all these other things to kind of keep going through and keep working through. And I feel like there's a lot of commitment and energy across sectors to do that. So that's pretty exciting. Clearly, though, the strategies are different across those sectors and across those approaches, and so we really have to think about that. So for me, I started my talk earlier this morning with this idea of like, where do I fit? And the where do I fit is not, where do I personally fit, but what are the questions for a company like mine? What are the questions for a company like yours or for government or other these places? And I think there are a bunch of them. So how can I help is a good place to start. Where do I fit? How can I help? What can I do? What's needed for whom? Big question, how do people select the best or necessary option? So this idea that there are 40,000 of them, but we're talking about, do I worry about my weight, the steps, my food, my exercise, my sleep, where I'm going to shop, we heard all kinds of things today that we have to figure out. And if we are interested in all of those things, is there a different app for all of these, or is there one app for all of those, or how does it fit together in the context of our life every day, all day, multiple times? What does that mean? How much time does it take? How do I integrate that in my life? Because, we've got other things to do with work and our kids, and we're not all sitting around managing our health by apps in every moment, although we may need to. Clearly. And as Michael said, what does this mean for me? So putting this into context helps people make those decisions. But these are higher order cognitive decisions that not everybody's equipped to make on their own without that help. So who are the helpers? And we talked about a whole bunch of helpers today in technology. Haven't mentioned at all community health workers. I think this is a prime area where community health workers are really poised to step in and do work that they do all over the place, all the time, really in an acceptable way. This stuff isn't so hard that they can't be trained. I think communities love it. So really missed that in the conversation, but hope that it comes back. And also, I mentioned health insurance this morning. I think it's the only time the word came up, but in the context of all the other decisions that we're making, health insurance is huge right now. Figuring out what to do with that and how we use our technology to manage our insurance in the context of our health is a big deal. Thanks.
Jennifer Dillhay, Arkansas Department of Health Roundtable member. I could say ditto to so much of what I've heard in terms of the comments. So I would like to just say a couple of things that have hit home to me. One is the importance of community, because we will always have people who truly struggle with low health literacy and interacting and navigating with the health system. And it becomes incumbent on the health system to provide navigation, care coordination, case management, that flip side of health literacy. I think the health system is going to have to reconfigure itself to help with the data part of it too. There are going to be many people who cannot use their patient portals. They won't be able to understand them and do the technology. And to have a system that is truly person-centric, we're going to have to reconfigure ourselves to make that happen. That reconfiguration doesn't have to all happen within the system. There can be entities like insurance navigators, community health workers, and others, librarians. There's a whole, but we've got to give some thought as to that part of it, because we're always going to have people who struggle, and we must help them. And that's where the community comes in. So, and it's that person-centeredness, the importance of the community, I think, is going to be what helps us see our way out of this. So, thank you.
Michael?
Michael Pasciorlo, first meeting as a member of the Roundtable. Thank you very much. I'd like to click like on several things people have said. In particular, calls for participatory evaluation and research from the beginning through the end, and several people have called for evaluation, and Rob specifically said, called this out. Health literacy can be really a fulcrum for building and assessing these systems, which I think is great. If you tell me that there are tens of thousands of these things, well, we need an app. All right? Except that I don't think it's really ripe right now, because so many of them really don't meet the needs of the vulnerable populations that I think we need to focus on. So when you say, Alicia, I think you're right, that there could be a market failure, and the market will take care of the digerati. And the question is, how do we as a group call the market to take care of the vulnerable population? And the digerati can be fine. So anyway, one thing that made me feel, so Winston, I was so inspired by several things you said. I actually going to go over and give you a hug later. And so I know, maybe protect yourself, right? But But one thing that I noticed in your comments at the end is that you're a lot nicer than me. Because you were like, oh, we need a taxonomy. Well, another way to say this is a lot of what we've heard about these apps is that they're really rudimentary. And that actually, much of what we were doing is that we were reactive to the stuff that's there, as opposed to kind of building from the beginning and saying, what are the things that our patients need to do? How can software help them? How can patient-centered HIT be created that will actually meet the needs? And you started to make a taxonomy of where those things are, and that's very nice. So I'm gonna, but I would, maybe I'm a little grumpier, or maybe I'm just influenced by a more complaining culture. My community says, no, this sucks still, and there's a lot of room for improvement. So there you go.
Hello, I'm Linda Harris, and I'm on the Roundtable. I'm also a proud member of the Planning Committee for this day, and I want to thank my fellow planners for this meeting. But I also wanted to, because I am on the Planning Committee, and I realized how hard it was to decide what would go in, and there's a lot left out. And so what occurred to me today is that we've really been app specific, and that's where the kind of the state of the art is, really all these apps. But I wanted to just point out one story of a system where they've really gone far beyond the apps, and I think it can kind of give us hope that once technology is incorporated into a system of care, and the patient is the driver and the patient data are the drivers of care, and it's connected to outcomes, it really works well. And that's with the VA. I'm really sorry we didn't have time for them to be here today, but I've actually worked with them on a project, and you may have as well. It's a care coordination project that started down in Vision 8 in Florida. And I'm going to just spend a minute telling you how that works. The first thing that happens is a social worker and a provider go into the home. These are very vulnerable folks. These are folks without a lot of education and on very low income. They're retired, the vets, for the most part. So they go in and kind of do an assessment of that family situation. And then they bring in a very simple technology that's text-based phone system. And that patient, and the ones I worked with, were patients who had just had chemotherapy, cancer patients. And so the project was tracking their symptoms. But the tracking was done where every day the patient and his caregiver provided information into the system every day, and they were extremely faithful at that. If the systems, such as, let's say, fatigue, reached a threshold, that's when a caseworker who was monitoring like 300 patients and their families got a signal that Mr. Jones is in a lot of pain. His pain threshold has been reached, and that moment in real time, the pharmacy would be called in the community, and that pharmacy would head out to the home if they weren't able to manage that pain. The really nice thing about that, it is really patient-driven, data-driven, and also outcomes-driven. And because the VA has been able to demonstrate that this system dramatically reduces unnecessary hospitalization, they've now expanded through the whole country. So this is just a little example of what it's going to look like when we have more accountable care organizations where outcomes really matter, where you can have virtual systems like the VA has right now. And it's not just about little apps and everybody trying to figure out an app. It's really about fitting technology that is patient-driven, designed just for the patient to not only get information, but be a partner in care, where they are really driving the solutions, and when that happens, they are able to stay out of the hospital. So I am delighted to kind of share with you that example of where I think this is going. We had two examples of that today from Alex, I think, and Kathy, who are beginning to show us how, when the technologies are kind of incorporated into a system, what it can look like. And I think the VA is out there showing us where ultimately it can go. And I think it's a very promising future. And I'm really pleased that we could all be sharing all of these stories today.